So, good morning, everyone. Today we have another talk by Professor Vedanthan, and that is about lung immunology. That is about lung barrier to various kind of insults, whether they are infections or other agents. I invite Professor Vedanthan to start his talk.
Thank you, Dr. Meenu Singh, and I appreciate the invitation to address your group. And today is a very important, at the same time, a very basic talk, because we are going to talk about respiratory barrier in normal people as well as in a few disease states. I am trying to confine the disease states only to our specialty in allergy asthma. So this, let me go ahead in the screen. Let's see. Respiratory mucosal barrier, normal versus diseased. Okay. Before we start, what I wanted to do was just go through some basic physiology, very basic anatomy, as well as also point out the situation in the type of environment that we live. It is a tough environment. Yesterday, we talked about pollution, and we all know that it's not only pollution, we have so many issues. We are bombarded by noxious agents, gases, viruses, temperature changes, many drastic situations happening like forest fires, where we're exposed to a huge amount of particulate matter, temperatures, and smoke, fumes, dust, you name it, and allergens. But a lot of us seems to survive all these onslaughts from Mother Nature. So that means we have a very, very tough human body. The human body, we may look more susceptible, but actually our tissues are very, very tough. And respiratory barrier, skin barrier, gastrointestinal barrier are the three major areas where we are directly in contact with external atmosphere. And so obviously these barriers have to be very tough, and respiratory mucosal barrier is a tough one. Now, what is the main function of a barrier? Barrier is to protect us. And protect from what? Protect from damage, protect from diseases, protect from inflammation, protect us from infection. So that means it is more than just a physical barrier. It should be, it serves, it is an immunological barrier, it's an antibacterial barrier, antiviral viral barrier, anti-allergic type of barrier. So it is a multifunctional barrier. So we are going to look at these important issue and see how our respiratory is designed that way to serve that very, very important purpose. Now, some of the basic facts is our human respiratory tract has a surface area which is huge. Each one of us in the chest has got tissues like the two lungs that we have. And if you sort of spread it out, it will sort of cover half the tennis court, or 80 to 100 square meters. That's a big surface area. Adult nose and sinuses are 100 to 200 square centimeters. At every minute, we are breathing in 6 to 12 liters of air every minute. 10,000 to 11,000 liters of air is moving in and out of our lungs every day. This is a 24/7, 365, which means with our knowledge or without our knowledge, we are inhaling huge amounts of pollutants, infectious agents, pollens, different gases, other so many noxious agents, and we are unaware of it, which means our body is doing a fantastic job in protecting us against all these known and unknown noxious agents. And that is how the barrier works and our immune system works. So it's a very, very efficient and extremely well orchestrated system. If you look at our respiratory tract, we have what we call as a lower respiratory tract, upper respiratory tract. Upper respiratory tract starts from the nostrils, goes until the larynx, and after that, it is lower respiratory tract. So if you look at the normal nose, we all look at people's noses and say, hey, his nose is, he looks like an Amitabh Bachchan nose. He has got a nice looking nose and all that type of stuff. He has a long nose, he has a short nose, he has a flat nose. But external examination of the nose doesn't give us much information. Most of us, except a few specialists like ear, nose, and throat, allergy specialists, do not examine the nose at all. Most of the doctors will, even the patients are conditioned. When they come into your office or you want to examine him and he's already saying, open his mouth, and you're looking into his mouth and throat. Very few doctors do a good examine of the nose. As our job is to check the patient from head to toe, but some tissues, some organs we examine in much more detail. That is, one is the skin, next is ENT, ear, nose, throat, and lungs. So every allergy specialist has to examine the nose in detail. He or she should be aware of the anatomy and physiology of the upper airways. So if you look inside the nose, how much of the nose can you see with a normal exam, even with a simple speculum? Only 20 to 30% of the nose. That means 70 to 80% of the nose is invisible to us. We do not know what we cannot see it. So nose is a hard one to examine. That is why when we are not too sure, we do a rhinolaryngoscopic examination, a rhinoscopic examination, which will give us a much better, almost like excellent way of evaluating the upper airways from the nostril until the larynx to this rhinolaryngoscopy flexible. And that is a part of the curriculum that we teach all our students. This is a thing that overlaps the ENT specialists, but allergist doctors, we do it. So if you look at the nose from outside looks like it is extending upwards, but actually it extends backwards. It goes anteroposteriorly. The nose extends about a couple of inches, and that is called the floor of the nose. Then you have these turbinates. These are like shutter-like structures on which you have mucous membrane, and it is all filled with significant amount of vascular tissue. It is cartilage beneath that, and you have what we call a sconcha. That this is sort of a empty space below each of these turbinates. So instead of going through all the detailed anatomy, what I want to impress upon you is by the minute that you inhale the air, whether it is at 20 degrees Fahrenheit or 30 degrees Fahrenheit, and it is dirty, whatever it is, by the time it reaches the throat, nose does something unbelievable. It humidifies the air, it filters the air, it warms the air, it slows down the air. It has been estimated when we are breathing, air enters the nose around 20 miles an hour. And by the time it reaches the throat, it is very, very slow. And it will be 100% humidified. It will be at body temperature, 98 degrees Fahrenheit. by the time it reaches the throat, pharynx. So nose, what it is doing, it is preparing the air for the lungs. It is warming the air, it is filtering the air, humidifying the air, cleaning up the air, because it is very important that warm, humidified, purified air has to enter the lungs. Otherwise, the lungs do not have any other mechanism to cleanse the air. And you will get certain damage, because if you're just breathing through the mouth, it is not good for your lungs. So what the lungs does, it conducts the air, it does gas exchange, it also slows down the airflow. But the main function of the lungs is conduction and gas exchange. And all the purification and humidification, temperature control is all done by the nose. So it is very important for us to realize the importance of nasal breathing in all our patients. If you want to have good lungs, you need to breathe through your nose. I have already gone through these slides in my just brief description. And as I was mentioned to you, because of the type of amount of air that we are breathing, we are also inhaling huge amount of particles. 80 to 90% of these particles are caught up in the upper airways, in the nose itself. And only if there are very small particles like 2.5 micron, PM 2.5 or up to 5 may go into the lungs, but definitely anything like 10 and above will be caught in the upper airways in the nose. So only very much purer air enters the lungs. So, and if you look at the respiratory tree, it keeps on dividing into bronchi and bronchioles, and until you have these alveolar sacs. Until you reach the alveolar sacs, it is covered with the mucous membrane all the way. And even the alveolar sacs have a single layer of the mucous membrane. We will talk about that cells. And gas exchange takes place in the respiratory bronchioles. Alveoli have a thin wall specialized to promote diffusion of gases. By the time it reaches the alveoli, there is no movement. It is more of a Brownian movement or a diffusion between the gases. And each lung has about 300 to 400 million alveoli. As I told you before, the total surface area is huge. And I think the lung keeps on growing. The lung is not completely grown at birth. It reaches almost adult level around 4 or 5 years of age, but it keeps on growing until probably adolescence, around 15, 16 years of age. So the summary is important. Nose prepares the air for the lungs. Lungs conduct and exchange gases. And upper and lower airway are very much connected to each other. They are almost like a unified airway, or United Airlines, we call it. And whatever is happening in the upper airways can influence the lower airways. Any type of allergies in the upper airways, like allergic rhinitis, can cause definitely some component or cytokine release, some interleukin release in the lower airways. So again, to stress the point, the nose breathing prepares the inspired air for the lungs. Mouth breathing does not prepare the air for the lungs. Now, when you breathe, the first area of contact is the vestibule, the very, very important area, because it can sort of determine how much air gets in and out of the nose. And that particular area, the opening of the nose is lined by stratified squamous epithelium. That is several layers of this very, very tough mucous membrane, stratified squamous. There is no cilia. Why is it stratified? Why is it squamous? Because we need something tough as skin right there, because as I was mentioning to you, when we are breathing air directly from the atmosphere, it could be very cold, it could be dirty, it could be coming too fast. So you need a very, very strong mucous membrane withstand that type of environment. Ciliary, like a columnar epithelium, cannot handle that type of onslaught. So the only type of epithelium that can handle it is stratified squamous epithelium. So the type of epithelium that we have is based upon the airflow. When the airflow is very, very rapid, it is fast, and it is coming directly from the atmosphere, you need stratified squamous. Once the velocity of the air change significantly reduces and the airflow is much reduced, then all the different, the mucous membrane also changes. It becomes ciliated columnar epithelium with cilia, because that is when the mucociliary function starts. Mucociliary function is possible only when the airflow is very slow. And that is what happens once you enter the nose. The airflow is, the rate of air, the air movement is definitely diminished significantly. And then the cilia, ciliated epithelium will start working on it. It's called mucociliary apparatus or mucociliary clearance starts. And that is very, very important. Clearance is very important. Now, I'll come to that in a minute. There are 3 cell types in the nasal epithelium: basal cells, goblet cells, and columnar cells. Each has its own function. Each has its own different type of anatomy. The basal cell, you are seeing the diagrammatic fashion, is a sort of a stem cell. From the basal cell, other cells are also formed. It can become columnar, it can become ciliated, it cannot ciliate, non-ciliated. So it is sort of a stem cell type of thing, basal cell, which is attached to the basement membrane. Then you have this ciliated columnar epithelium with cilia, and there could be non-ciliated columnar also. Now, goblet cells. Goblet means it. The reason why it is called goblet is it is cup shaped. The main function of the goblet cell is production of mucin. What is the function of mucin? Not only the transport of all the pollutants and all the particulate matter that we have, but also has antimicrobial, antiviral, and protective function. So mucin has a lot of different functions. So, and that is produced by goblet cells. And the ciliated cells, columnar, are the ones that transport the mucus from the nose to the back of the throat, to the pharynx. So it is sort of moving backwards. So what is happening to the mucus that is produced below in the trachea? Actually, there is ciliated epithelium is also there. Ciliated columnar epithelium is also there. It sort of moves the mucus in the opposite direction. It moves it upwards. So everything comes and gets collected in the posterior pharynx. So in the nose, the cilia movement is driving the mucus backwards. In the tracheobronchial tree, it is driving the mucus upwards. Otherwise, you will be filled up with mucus in the lungs. It is a continuous, extremely efficient, what is that? Conveyor belt system, which is right there. It is sort of moving, conveyor belt, so many millimeters that it moves. And what it does, everything gets collected in the posterior pharynx. And what we do is, without our own knowledge, every few minutes we are swallowing. We are swallowing all these particles and all the dirt that is in the air that is not supposed to go into the lungs. It will all gets collected in the posterior pharynx. It goes into your stomach. And if you do not swallow, you feel very miserable. And it's a normal reflex that every few minutes we are swallowing. And if you sort of get aware of it, you will come to know how often that we are swallowing that mucus which is continuously produced. So if you look at the mucus in the nasal epithelium or even in the bronchial epithelium, there are two layers, a gel layer and a sol layer. The right beside the outermost layer is the gel layer. It is sort of thick and it is sort of a escalator type. It keeps on moving slowly. It is the one that catches all these different particles, particulate matter. Everything gets, it is sticky, it gets caught to it. And the sol layer is a very watery type of layer which of the mucus, which is in which the bacteria will keep on moving. And the source of these mucus is the submucal glands, and the goblet cells are very much responsible for it. And this mucus, as I told you, is not only transporting all these materials, but also has many other functions, immunological functions. It has immunoglobulin A, it has several enzymes, it has mediators, it has cells, and it has albumin. So it is a very efficient way of keeping our respiratory tract not only clean as well as clear of excessive mucus, but also protecting against all these noxious bacteria, viruses that we all have. So it is a part, the whole epithelium is a part of the innate immune system. It is a part of the innate immune system. The respiratory tract, the mucous membrane, all these nasal secretions, the skin, the gastric secretions, saliva, all portion of the innate immune system. We come to this, we are born with this ready-made immunity, innate immune system is, and these are all parts of the innate immune system. So nose prepares the air for the lungs. The inspired air is humidified, as I told you, temperature controlled, and nose is the mirror of the lungs. I'm sorry about the repetition. And these are all some comorbid conditions. I don't want to get into this now, but let us move on to respiratory epithelium. Now, if you look at the respiratory epithelium, depending upon the anatomical location, changes its character. There are so many different types of cells. I told you about the basal epithelial cell, you have ciliated epithelial cells, you have secretory cell, you have mucus producing cells like goblet cells, cuboidal epithelial cells, alveolar epithelial cells, smooth muscle cells, dendritic cell, innate lymphoid cell, alveolar macrophages. So that means it's not only producing mucus, there are cells that are a part of the immunological system, like dendritic cell is very much of a part of the immune system, both adaptive and the innate system. So it is very important in the production of or facilitating the production of cytokines and getting these T cell, B cell. Dendritic cell is also a very important antigen presenting cell. It is a part of the immune system. So if you look at the different type of cells that you have in the tracheobronchial epithelium up on the top, you have the clara cells, the ciliated cells, as well as as well as let's see what you have, goblet cells. So as you move down, the ciliated cells become less and less. Below at the level of bronchiolar area, it becomes more just columnar only, no cilia. You don't need cilia. As you go down into the alveoli, it becomes a single layer of squamous epithelium. So the respiratory epithelium changes depending upon the area, and it has a couple of major functions. One is physical barrier. It's an immunological barrier. It also has a mucociliary clearance. It produces inflammatory mediators. All these actions prevent disease as well as any type of major inflammation. So these are the diagrammatic fashion of different human airway epithelium. One is the mucus secreting goblet cell, ciliated cell, basal cell, club cell, basal membrane cell. These are all important cells, and some of the functions are ciliated epithelial cells are essential for proper functioning of the mucous membrane, and they are impaired in asthma and allergic rhinitis, which we'll talk in a minute. Mucus secreting goblet cells, which I talked to you, is very important in not only trapping of all these pollutants, but also immunologically, it is very important. Airway basal cells work like stem-like cells. They can get converted into ciliated epithelium or goblet cells or whatever. And then you have secretory cells in the small airways that is called club cells. Clara cells are the non-ciliated bronchular secretory cells, and they are the ones that secrete pulmonary surfactant. And you also have chemosensory cells, neuroendocrine cells, ionocytes it is calling, and they have all certain specific functions. So you have so many types of different cells acting in unison in the respiratory tract. And how do these cells are so tough? How is it acting as a barrier? The way they act as a barrier, it depends upon how these cells are attached to each other. These cells are attached to each other in different ways. And there is what we call as apical junctional complex at the level, at the apex of these apical area of these cells. You have what we call as tight junctions. These are a group of proteins that keeps the cell attached to each other. Then you have adherence junction, another group of proteins which sort of wraps them around. And desmosomes are again like wire-like projections which are keeping them all attached to each other. And hemidesmosomes are like anchoring agents. They anchor these cells to the basement membrane. So basically, all these tight junctions, adherent junctions, desmosomes, hemidesmosomes are structures that keeps these cells tight. And that is why this is a very important part of what we call as epithelial integrity. To maintain epithelial integrity, you need a very, very good functioning apical junction complex. This is this basically is telling you that gas exchange takes place in the respiratory bronchioles, and alveoli have a very thin wall specialized to promote diffusion of gases. And there you have basically simple cuboidal or simple pseudostratified columnar epithelium. And as you go deep into the alveoli, it is a single layer of simple squamous epithelium through which gases are exchanged. And then you have alveolar macrophages. And there are two types of cells, type 1 cell and type 2 cells. And here where the gas exchange takes place, surfactant are produced. So alveoli are the area where you have the gas exchange, and there is no real movement of the air. It is mostly a Brownian movement, and very, very important part of the gas exchange. And this is how the gas is exchanging between the capillary and the air sac. So, and as I was mentioning before, you also have the microbiota in the mucous membrane, and you have physical barriers. And there is also an interesting thing called taste receptors. Taste receptors, the way we understand it, is actually in the tongue, but taste receptors are a part of the innate response, immune response. There are extra oral taste receptors. They are present in this in the taste receptors are present in the respiratory tract as well as in the intestine. I think, I don't remember exactly, but they are present. Other than the tongue, you have taste receptors in different places, and in the definitely in the respiratory tract, you have these taste receptors, and they act as a signal to the innate immune response. You also have antimicrobial proteins like beta defensin, surfactant proteins. These are all part of the immune system present along the respiratory tract. So the respiratory epithelium changes based upon the airflow. The integrity of the mucosa is very efficiently managed by these innate mechanisms. So it is not just a physical barrier. Immune system is intimately connected to the respiratory mucous membrane, and intact epithelial barrier is very crucial for prevention of any of these disease or any of these inflammatory conditions like allergies. So if you look at why people get allergy, we say, oh, it's a genetic problem. But what is the genetic defect? Is impaired epithelium permeability. That is one of the basic defects in allergy, is impaired epithelial integrity, and that allows all these different outside agents like pollens or dust mite or what to enter through these defective epithelium and cause much more damage because of the protease enzymes that they have. Mucociliary junction function apparatus. So I'm sorry, I should have done this. Okay, I'm sorry, I didn't do that. So mucociliary function, there are three components: cilia, mucous gel, and periciliary layer, I mentioned to you, and as well as the amount of mucus that is produced, about 30 ml a day. And the ciliary movement is decreased in certain disease states like asthma, and environmental tobacco smoke definitely paralyzes the ciliary movement. If you look at the cilia, usually these columnar cells, about 100 cilia per cell, could be more sometimes, and they have what they call as a two-stroke pattern of beating, and they strike about 700 to 1,000 times a minute. They are very, very synchronized and extremely efficient, moving the particles in one direction at a speed ranging from 1 to 20 millimeters per minute. And temperatures can definitely influence the ciliary movement. Let's see, I have talked about one thing, and there's one, I told you this mucociliary apparatus is a part of the immune system. And one word about mucus that is produced by the goblet cells. There are two types of mucus, and depending upon the genes play a role in it. There is mucus 5B, and one of them, 5AC, is the one that shields the epithelial surface, and the mucus 5B is the one that regulates the leukocyte function. This is the mucus 5AC is the one that is much more sticky, and it is increased in asthma and allergic conditions. So the mucociliary apparatus, the function is transportation, defense, cleansing, catching, and controlling the flow. And the airway mucus is of major importance, effective epithelial barrier. As I mentioned to you, there are two portions, and under genetic control partially, and also influenced by environmental agents. I'm trying to see if there's a movie. Sorry. Can I? and come back again. Sorry about this. Let me see. We covered this already. And some of the factors that can slow the mucociliary transport is cigarette smoke, dehydration, positive pressure ventilation, high inspired oxygen concentration, cold temperature, hypoxia, and sorry about that, and anticholinergic drugs, viral infections, allergies, all these things can definitely interfere with the mucociliary transport. Normal versus allergic nose. In a normal nose, the cilia are intact, the gland, the basement membrane is thin, the epithelium is intact. But when you have allergies, you have loss of epithelial integrity, loss of cilia, intense cellular infiltration, especially eosinophils, thickening of the basement membranes, hypertrophied mucous glands, and these are all characteristics of allergic rhinitis. And the changes in the diseased nasal epithelium will due to epithelial barrier dysfunction, and also these different allergens like dust mite, cockroach, pollens, cases that can directly damage the mucous membrane. And when the mucous membrane is damaged, the barrier is permeability increases, and that becomes a vicious cycle. More of these allergens will enter and cause more damage. And the same, and also these changes will make the child have less immune response to viral infections. So this may be one of the reasons why allergic children get more viral infection than normal children, because of the damaged epithelial integrity and dysfunctional epithelial tight junctions as well as adherent junctions. So the membrane is not working right. It's a leaky epithelium. So because of all this, there's a deeper penetration by allergens, bacteria, viruses. And this is sort of a vicious cycle in these patients. In allergy, in asthma and COPD epithelial changes, the same thing happens where there's a damage because of the allergens. But the allergens with the protease activity does not affect the normal people, because this is a genetic defect. The genetic defect is epithelial integrity is a little bit weak in these people with allergies and people who are allergic, more prone for asthma. And that is why the damage occurs much more easily in these people. And there are what we call as asthma susceptibility genes that are expressed in the epithelium. And these changes, what I am talking about, some of the epithelial damage occurs even before the onset of inflammation, occurs extremely early in the course of the disease. So the disease is setting in. There are no signs, there are nothing like no signs of inflammation yet, but the epithelial damage is occurring already. Epithelial changes occurring very early because of this mechanism is because of the gene environment interaction. So asthma is an epithelial cell disorder. It is an epithelial cell disorder. Means we really have to start treating the epithelium much, much earlier in the course of the disease to get the problem under better control. And because of this dysregulation in the epithelium, the mucociliary apparatus also gets modified. There is increased mucus because of the increase in the goblet cells, increase in this MUC5AC protein, and that is why the mucus gets thicker. And also it is a sticky mucus in asthma because of the type of mucus that is produced is different. And there is, because of that, there is decreased ciliary beat frequency, or even dyskinesia or erratic movement of the cilia. And this, all this combination causes like hypersecretion of the mucus, ciliary dysfunction, and causes patients to cough, have mucus plugging, like we are all quite familiar with, and causes definite airflow obstruction. And this is sort of summary of what is all going on from the environment. You have all these different noxious agents, and that causes decreased defenses as ciliary dysfunction, production of mucins, weakened tight junctions, and the integrity of the epithelium is decreased, and that causes damage to the epithelium, causes more bronchial hyperresponse, and and this happens more in genetically more people. These are all the different genes that could be involved on the upper right hand side, and such people who are genetically prone will be affected much more significantly adversely by cigarette smoke, air pollution, rhinovirus, alternaria, proteases, allergen. So all these things will affect these people much more than normal people because of the genetic susceptibility. So this gene environment interaction will end up in the disease. So epithelial changes start very, very early. Genetically prone individuals are affected. The bronchial hyperresponse, inflammation, remodeling will follow that. And direct damage also occurs due to the epithelium by the proteases from these different inhalants. So epithelial disease is what asthma is. So happens in COPD to some extent, environmental pollutants, viruses, allergens also. The type of mucus produced is a little bit different. It is less viscous in COPD. And these are all pollutants that can affect asthma through the impaired ciliary apparatus, increased permeability, again, epithelium, and oxidative stress also. And these are all a list of different agents, environmental factors that through different mechanisms can affect the barrier function. Like protease allergens can elicit both non-Ig mediated as well as degrading the barrier proteins, increasing the epithelial permeability. Detergents do that. Cigarettes and e-cigarettes increase the alveolar epithelial permeability, decrease that level of tight junctions and AJ proteins, and disrupt that integrity of the epithelium. Ozone causes cell stress, desquamation of the epithelium, protein leakage, as well as all this particulate matter again damages these and suppresses the function of these epithelial integral factors. And so what it means is all these different environmental factors that we are blaming is primarily, to start with, are affecting the epithelium first. So epithelium is the most important part of the equation. And that is the first one that gets the onslaught of these mechanisms that are involved. And because of this epithelial damage, which is occurring in genetically more prone people, the environmental agents will cause further damage. And because of this combination of gene epithelial interaction in the susceptible individuals, the disease states will start. So when we have this type of issue, what do? Fortunately for us, the medications that we use works for this damage. The inhaled steroids, corticosteroids, will restore the epithelial integrity. It is because of inflammation, it will reduce, and corticosteroids are, that is why they are so effective. They may not be curative, but definitely very highly effective. And the epithelial damage is minimized by these corticosteroids. And because of all these different cytokines, interleukins that are released. Nowadays, we are using very, very specific target therapies, anti-IL-4, anti-IG. There are so many different biologicals. They also will help in this situation, because it is not just bronchodilators that we are worried about. It is much more specific. Not only just steroids, but we are using very powerful biologicals which are affecting these targeting the specific interleukins and cytokines. So anti-inflammatory therapy and IL-4, these biologicals have been extremely effective in getting the asthma under better control. So I see inhaled steroids induces the tight cell to cell junctions, and reduces the inflammation. It increases the ciliary cell numbers. It prevents barrier dysfunction even in smokers. So that is one reason why inhaled steroids have been one of the best drugs that we ever have. And it has basically saved these patients from continual damage. Even bronchial biopsies obtained from asthma patients showed that inhaled steroids reduce the inflammation and increase the number of ciliary cells. So it is really has come as a God-sent medication for us. And if you look at this slide, this basically tells what are all the destructive elements: cigarette smoke, air pollutants, oxidants, respiratory virus, rhinovirus, RSV, and certain bacteria, protease allergens. All these things are damaging, destructive on the epithelial structure through different mechanisms. But what are protective are the glucocorticoids. The glucocorticoids, budesonide, fluticasone, all these, and beta-2 adrenergic receptor agonists. So the things that we are using, some of these growth factors, fatty acid metabolites, they all seem to be working like protection against this damage. So anti-inflammatory agents highly effective in reducing the damage induced by these different agents on the susceptible people's epithelium. So a few words about nasal saline irrigation, which Dr. Meenu Singh brought up, and that is the picture that she sent me. It is an old practice, thousands of years old. Our ancestors knew that keeping the nose clean is an integral part of better breathing and better living. They knew that. And that is why they came up with Jalaneti. And they also have many kriyas, which are more uncomfortable actually for us because we are not used to all this. And they are also used for allergic conditions and for several respiratory conditions. But this is one of these simple ones which has helped. But even native path is not that easy to use unless you bend it in a particular way and you do it. Some people get significant sinus headaches because of that, because it goes into the wrong direction. So that is why we use the just simple nasal irrigation of the sinus. So even if you don't use nasi part, you can just sniff it. So one of the things we do is not tap water. Don't use tap water. Use distilled water. You can use saline. It will be the best thing. Put it even on your palm and just, and what you could do is don't take it in like, sorry, I don't know what happened. Okay. You can't inhale it through both the nostrils. You have to inhale from one nostril at a time like that and blow very slowly. And that is enough. What it does is it is first clearing up the mucus, clearing up all these mediators that are released. I was just telling you all these different IL-4, IL-13, all these things will be there. They will all be cleared out. And the mucus that is that mucin that I was just telling you, the thick mucus that is secreted because of inflammation sitting on the cilia is also cleared. So the ciliary function is restored by saline irrigation. So it's a mechanical thing. There is no medication involved. So it reduces the microbial antigens, gets rid of these inflammatory mediators. It restores the ciliary functions and clears all this excessive nasal secretion. So I think this has got a definite place in our specialty. It has got a nasal irrigation is effective as an adjunctive therapy for symptoms of chronic rhinosinusitis. It is like a grade A evidence for that. Effective adjunctive treatment for symptoms of irritant rhinitis, allergic rhinitis, viral upper respiratory tract infections, grade B, mild to moderate rhinitis of pregnancy, acute rhinitis, grade C. So rhinosinusitis and allergic rhinitis and irritant rhinitis are the things that we see very, very commonly, and nasal irrigation is a good thing for these patients. Thank you very much. Today was a little bit of a little, it is sort of a complicated talk. It's a lot of basic information there, more than clinical. So I'm sorry if I sort of bored you to some extent in the middle. But important thing about this particular talk is, although it has got lots of basic stuff, a lot of it is clinically applicable. And also what we are doing, now it makes a sense for us to stress upon using saline irrigation, intranasal steroids, and we know there is the disease very early. And so it is, instead of waiting on the steroids, it's a good idea to start it very much early, because now we know epithelial damage occurs first and the inflammation sets in very, very early. Thank you very much for your patient hearing.
Thank you so much, Dr. Vedanthan, PK, for your masterclass on barriers, respiratory barriers. I think it was a treat to listen to you, and I'm quite sure that all the researchers, especially, they have learned a lot from this particular talk. And I think each slide was like a topic by itself. And with your masterly approach and being so knowledgeable about everything, it's really made it a wonderful exercise. So, any burning questions with people who want to ask PK about barriers? In fact, it's all about physiology and immunopathology, which occurs in allergic disorders.